In this video, we'll go over the steps on how to insert a bronchial blocker. The ARNC bronchial blocker is a wire-guided catheter with a loop snare at its distal end. It is intended for endobronchial blockade of the left or right lung for procedures that require one lung ventilation. Some of the indications for a bronchial blocker are children younger than 8 years of age, patients requiring nasal tracheal intubation, patients with a tracheostomy, if there's a single lumen ET tube in place, and patients requiring intubation after surgery and you want to avoid changing a double lumen tube for a single lumen tube. The bronchial blocker comes with a specialized adapter. As you notice, it has 4 ports. This port allows for connection to the anesthesia circuit. The top port allows for placement of your fiber optic scope. The gasket seals so you can provide positive pressure ventilation throughout the bronchial placement. And this port allows for placement of the bronchial blocker. And finally, the bottom portion connects to the patient's endotracheal tube. Prior to the assembly of the bronchial blocker, you must ensure that the bronchial blocker is lubricated. An aerosolized silicone spray is used. The spray can also be used on the fiber optic scope. Okay, now let's see how it all comes together. So once you have lubricated both the bronchial blocker and fiber optic, you can assemble them prior to connecting the adapter to the patient's endotracheal tube. The fiber optic is passed through the loop snare of the bronchial blocker. The loop snare is now cinched tightly around the tip of the fiber optic. Now that your adapter is assembled, you're ready to connect to the patient. The bronchial blocker and the snared fiber optic are inserted through the endotracheal tube. The multi-port airway adapter is now connected to the endotracheal tube to allow for uninterrupted ventilation during the positioning of the bronchial blocker. The coupling of the fiber optic scope and the loop snare of the bronchial blocker allows for the fiber optic to guide the bronchial blocker into the desired area. Once the carina is visualized, the bronchoscope is advanced into the area of the lung to be blocked and deflated. Once the area is entered, the fiber optic is held stable. The loop of the bronchial blocker is advanced and slid distally off the fiber optic. After slight retraction of the fiber optic, the blocker is advanced or retracted to place it in its final position. The balloon is now inflated under bronchoscopic visualization. You must ensure that the balloon fills the entire lumen and does not herniate out of its place. The fiber optic scope can now be removed carefully. Once it is removed, the port can be closed. The blocker port of the adapter is now tightened to prevent the escape of gas and also so that the blocker does not move out of its place. Once final position is confirmed, the guide wire can be removed and lung deflation can begin. The lung will deflate passively, but lung deflation can be assisted by aspirating the port with a syringe. The patient is now ready for surgery.